Hello, everyone, and welcome back to another episode of Let's Talk About Cannabis and Healthcare. My name is Drudys Ledbetter. I am your host, a nurse, and the founder of Project Destigmatize Healthcare. I'm also a healthcare strategist and recently wrote a book, Healthcare Cannot Manage What It Cannot See. Welcome to session number 9. This series, if you haven't been here before, it exists because healthcare is entering a period of enormous change. Cannabis use continues to increase across the United States. Millions of people are consuming cannabis, yet our clinical systems, our documentation, our research, our infrastructure, and provider education have not kept pace. Our goal isn't to tell people what to think about cannabis, but it's really to ask better questions. So each week we've been bringing across leaders in nursing, research, public health, and policy, in tech as well, to explore what healthcare currently knows, what we still don't know, and what systems are needed to be built so we can have the capacity to respond to cannabis entering healthcare. Today's conversation is one I've been looking forward to. Our guest is Megan Mbengue. I'm going to bring her on stage right now. She is a registered nurse, a cannabis researcher, an educator, and one of the most respected voices in cannabis and healthcare right now. I am so excited to have you here, Megan. Please, hello. How are you?
Hello. I am so happy to be on here having this conversation. I'm looking forward to this. Thank you for having me on.
No doubt. One of the things I appreciate about you the most is that you are willing to have the difficult conversations. Whether we're talking about therapeutic potentials of cannabis or raising awareness about conditions like Cannabis Hyperemesis Syndrome, you're consistently encouraging us to follow the evidence. And that's kind of what we want to talk about today. Even because I think sometimes the evidence challenges our assumptions. And because cannabis has had such a bad rep, we have a tendency to not want to talk about the bad. We just want to talk about the good and glamorize the plant. So today we're going to explore cannabis through evidence-based healthcare lens. What do we actually know? What do we think we know? What are the biggest gaps? And what does healthcare absolutely need to build over the next decade to make safer, more informed, more patient-centered decisions? I always start by not only welcoming you to the show, but also asking you to tell us a little bit about your journey and how did you even get into cannabis and into this field?
It's an interesting one. Most people in cannabis have, come from like a personal journey, right? But mine was more of a professional journey. And I was a hospice nurse, and we had this patient who was having back-to-back seizures all day, and she was on 5 or 6 different seizure medications with absolutely no relief. And I had not been taught about the ECS. I had not been taught about cannabis, other than prohibition, of course, as a nurse. And but I had read headlines that like CBD and cannabis were supposed to help. I had no idea where to start or what dose or what to give her or anything like that. But we ended up doing a transdermal patch on her because she had a trach and a G tube, and the seizures stopped right away with her, and she was so much more comfortable. And I was like, okay, there's something to this. And I think that this could be so beneficial for so many hospice patients, but how am I supposed to guide them if I don't even know what, I wouldn't know what to get walking into a dispensary. So how am I supposed to guide them? They need somebody. So that's when I jumped in the deep end. I started learning everything that I could. I started going to conferences. I got a master's degree in medical cannabis. And I started the company at the same time to really guide people on how to use cannabis as a safe and effective medicine. And then, we launched a product line along the way. We introduced psychedelics along the way. And now we're 4 years in, facing a lot of challenges at the, federal and state legislative level in the hemp space. But we have helped thousands of people over the years. So I think that's about it. That's the gist of it.
But I mean, that's very unique because most people do start as patients, and that's when they kind of get into it. I know that we haven't formally had a conversation before today, so I'll tell you a little bit about my story. I actually was raised Seventh-day Adventist, very religious household, My mother is a pastor, and I was in my 30s suffering from postpartum before I actually was pointed into the direction of cannabis. I
Mhm.
had been on 6 months of med trials. And I mean, every medication you can think of, we tried everything. I mean, every combination that you can think of, I had tried, and I could not get any relief. I couldn't sleep. I was suffering from severe insomnia. And my therapist one day was like, "Hey, have you ever considered cannabis? Because your problem is really like the insomnia. And maybe if we can get you to sleep, we'd be able to work through the rest of the stuff."
Right.
um, and it was like magic. It was hard to get. I think access became a very big issue for me at the beginning because I was in a state that did not have a medical cannabis program that was robust. They only
Mhm.
had oil. I was in Georgia. And then I had to like then learn about the medicine because as a nurse, I was a clinical director, and I was like, I do not want to end up on the news because I died of some random person's cannabis, right? And I began really thinking about like what is it going to take to actually learn. So then taught myself, and then when I jumped into the industry in 2000, um, I realized that the industry has no idea what we're doing in healthcare. They have no idea how to support us in healthcare, and
Mhm.
that it became very much the green rush. And I kept sounding the alarm and saying, "Hey guys, we should talk about this. This is medicine. We should do the things we do for other medicines, like med reconciliation and education, and then making sure people have access when they go home from the hospital or rehab, if this is something that they're using." And in healthcare, I like to joke and say, we don't talk about Bruno. We don't talk about Bruno at all. Like we just
Right.
don't.
Right.
It's like we know it's there and we're like, okay, we ask, do you take illicit drugs? They say no, but they have like weed earrings on, and we're like, okay, no, and then we just move along, right?
Right.
So I think that that's where my curiosity came into the space. And then as a leader, when the nurses were terrified of like taking people's cannabis from a can because they thought they would get high, or when I saw patients that were on warfarin have adverse drug reactions, or the stories that I've heard about people waking up during procedures
Mhm.
because they didn't disclose and they didn't use the right amount of anesthetic, I was like, okay, this is a clinical risk issue, and these
Yeah.
clinical risks are preventable if we
Yep.
talk about Bruno. So
Yes.
I think the good of cannabis is an easy topic. So we'll start there, right?
Yeah.
So I will first ask you, where do you think cannabis has demonstrated the most beneficial therapeutic potential? Like in your experience, you were in hospice, and I think that that's
Mhm.
typically the environment folks like to think of when they think of cannabis. But what else have you seen? You've dealt with thousands of patients. You actually helped some of my friends because I've
Yay.
sent them to you, and I didn't know what to do. I was like, I know a girl that does this, but I can't help you. So tell me, where do you think we have the strongest therapeutic potential for the plant?
I mean, there's so much potential, but I'll tell you, the top 3 reasons that people come to cannabis is for pain, anxiety, and sleep. And the medications that are available right now for pain, anxiety, and sleep oftentimes aren't, the root of a lot of pain is related to inflammation. A lot of the pain medications out there aren't doing anything for the inflammation that's causing the pain or the stress that can trigger the pain. And we're not, they're just not doing it, or they're doing it in a way that is leading to harm, with benzodiazepine dependence issues. Benzos are they're a beast to come off of, and opioids, and then sleep medications are a big issue also. So those there's so much potential there. But there's also potential, in epilepsy, with CBD in epilepsy is huge. It's such a safe medicine. I don't know why it's like a last line, not a first line, for epilepsy and autism and cancer treatment. Not only just the symptoms of cancer, but killing the cancer itself. Gut conditions, IBS, Crohn's, and there's just so much potential out there, and there's so much research to support this as well.
No, I love and appreciate that. I actually had Dr. Julie K. Johnson from the Massachusetts CCC, the chief of research, on
Mhm.
last week's episode, and we were talking about this. And I was saying there's so much research, and she kind of blew my mind when she said, we don't have the basic science to measure and standardize the research results and actually like with scientific rigor and use it to like guide other research to go a little bit deeper, because we're not using the same language and there's no like standardized research language for the scientist. And she thought that that was like a huge concern, that we need to build consensus around what is the plant, what is it to actually do, how does it actually work, and that a lot of the research is going for like specific directed therapies, obviously, because research is often paid for by the people developing the medicines, and they're attacking a specific diagnosis. But it made me think about, wait, like, do we not have a standard language? Like, because a lot of the research, when you're reading it, I feel like I understand what they mean and I understand where to pull the good information, but I also can see the perspective from a research point of view where they are very, stringent on how things need to look and be measured. So I wanted to get kind of your thoughts on that because you're a researcher as well. And I think there's a lot of research can sometimes become a misconception if we're not using this research and compiling this research and then reporting this research in a way that healthcare understands. So I guess my question would be, what misconceptions have you seen as a nurse researcher that are keeping people, providers, scientists, people that should care and should believe in the science, from recognizing cannabis as a therapeutic, like a component for healthcare?
Yeah, such a great question. And this is actually the project that we're doing with Society of Cannabis Clinicians right now, is that, the standardized medicine, we have the evidence pyramid, and the randomized controlled trial is like the gold standard of research, where you're comparing a single molecule to placebo, and then we're seeing if there's a statistical difference in those outcomes. However, with cannabis, because it's such a complex medicine, it's more than one molecule that's acting in the body. It's multiple molecules, and that's where the magic is the entourage or synergy of all of that working together in the body. It's really a reductionist approach to try to fit that into the RCT model. And as clinicians, we were taught that it's not safe or effective if we don't have an RCT behind it. However, with cannabis, we have to look at it through a different lens, through like a real world outcomes. Like, how are people using this in the real world? And can we look at that evidence and say, okay, like 5 milligrams or like a THC gummy is helping a lot of people with sleep. We're not seeing a lot of adverse outcomes. So is that enough evidence to at least try this in this patient safely, right? And that's really where I think where the big divide is that clinicians say if there's no RCT, it's not safe or effective. But yet we have millions and millions of people using it safely and effectively in the real world. So why can't doctors look at that evidence and say, okay, that maybe there's something here, let's try it on my patient? And I think that's such a huge divide, and it's a paradigm shift in the way that we look at medicine, in the way that we look at the research. And with Schedule 3, we're seeing a paradigm shift in the way that we regulate medicine, because Schedule 3 will not require FDA approval. It won't require a prescription or a pharmacy to dispense. Like, we're going to be able to allow patients to use Schedule 3 whole plant medicine. And that's a huge shift. So we have to also shift the way that we look at the research.
No, that makes so much sense. And the FDA pathway is typically how medicines enter healthcare, right? And I think one of the things that most people don't realize is that the FDA pathway gives you these outputs. It gives you like the list of indications for the use of the medication. It gives you the dosing ranges. It tells you toxicity, and it really builds the information framework for the recommendations to be clinically meaningful. And I think that my solution has always been, why not build the outputs with the current research rather than try to make cannabis fit into an FDA pathway? Why can't we use the data that we have and say, in these data points, we've seen exactly what you said, 5 milligrams works for sleep and it hasn't. Why can't we compile all that together And is there anybody doing that work right now, like saying, hey, this is what we know, and this is what it looks like
Mhm.
as an FDA output?
Um, there was a recent study done in Germany that actually looked at like real world use of cannabis, and I think they compared it to like prescription like Marinol or something like that. And it was such a well done study that it really matches what we're trying to achieve with cannabis medicine, that we're looking at these real world outcomes. And I think what we're going to see with, CMS and, Medicare allowing patients to use CBD, and they want the offices to start collecting data. It's like we are going to start to see that real world data. I mean, it already exists, right? Like we have real world data on our suppositories. There's so much real world data out there already on all of these different things. But I think we're going to start to see it more accepted, like with this CMS model and CBD coming up.
No,
But
absolutely. Tell us a little bit more about the CMS model and CBD. And because I know that there's reimbursement tied to it, and then there's a care pathway that needs to be built. And I know that you guys are working on something on that end as well. So can you like shine a little light for anybody who hasn't even heard about the CBD trial, as they're calling it
mhm.
out here? Can you give us a little more information on that?
Yeah, I'll give you what I know and what I understand of what I've heard. I haven't done a deep dive, but to me it sounds like um, that doctors' offices are allowed to purchase wholesale and then give the product to the patient and then collect data based on, based on that. The thing is, the doctor's offices aren't getting reimbursed for it. And it's definitely an extra lift to be collecting this data, and it sounds like it's being like put on that office. I could be completely off. Maybe they have built some infrastructure around it. They're only allowing like a very small number of CBD brands to participate. But again, like the financial responsibility and the data collection responsibility sounds like it's falling on the actual practice, and it's not something that's being reimbursed. So I well, we're gonna see how that, and maybe I'm completely wrong and completely off, and maybe there's somebody who knows a lot more about it.
No,
But
you're right along the lines, because I try not to be the one sharing all the info all the time. But
Mhm.
um, yes, CMS definitely put out essentially like a go try it if you will, and if you can prove the benefit,
Uh-huh.
we'll reimburse you. So that means that you have to build a care pathway yourself. You have to build the data set. You have to, again, access and acquire the medication. And you have to basically invest in this research that then the government will use in the future, and then get reimbursed. Right. And I'm doing air quotes because we don't have ICD codes. We don't have the traditional language to be able to code it for
Right.
reimbursement. So I think that it's nice. I think it's very nice. But I also feel like, I don't know, like I'm trying to be so polite. I feel like it's very nice that they are saying go forth and try. I also think it's very irresponsible for the amount of resources that we have, um, to leave it up to clinics and primary
Mhm.
care physicians and practice settings to invest in this research to prove to the government that it does work, to then get their money back. I think that that's not the
Right.
right approach, especially when we have a lot of research that's already showing us that we should be collecting the data. And I
Mhm.
want to spend like majority of our time talking about something that's like has me has me in a chokehold right now, which is cannabis hyperemesis syndrome, which I feel like also has you in a chokehold, because I've seen your post, and I was like, oh yeah, we got to talk, because this is the part where the bad comes in, right? And this
Mhm.
is the part no one wants to talk about. First of all, cannabis is not for everybody. I think we can all agree it is not for everybody.
See,
And
that's the
second of all,
thing. like, and sorry to interrupt, that's the thing, is not everybody agrees, is that you have people out there saying cannabis is an essential nutrient that the body absolutely needs to function, which is not true, because there are people who go through their entire life without a single CBD milligram or THC milligram, and they're thriving. So it is definitely not necessary. But that is the narrative that that we're up against, is that CBD or cannabis is safe and effective for every single person. But
Yeah. But no, it's not. And I know that, and I know most clinicians agree, because we're reading the research of what's happening. I think healthcare often struggles because it's either yes or no when it comes to cannabis. And even in our research about the cannabinoid hyperemesis syndrome, I think we are not doing the due diligence of collecting the actual data that will allow us to learn more about what's causing it. And you mentioned something earlier, how we typically go and do a root cause analysis and try to figure out what's behind the thing and what's behind the thing. And a lot of medications are not addressing the inflammation. They're not addressing the homeostasis. But then we have now cannabis, who has entered the chat, I like to say. And in most states, because of the lack of education, high THC is the thing to do. Everyone is taking high THC. People shop per THC levels, which has created, in Massachusetts in particular, a lot of lab fraud. So people lab shop to get a different label on their cannabis, so that, hey, this used to be 16% THC last week, but if I go to that lab, it's going to be 24, and it's going to sell faster. And I think that what we're not doing when we're not collecting the data is giving the industry an opportunity to build safety guardrails around what products should exist in an adult use infrastructure or in a medical program, because we are not talking about it, or we're not only not talking about it, but we're also not tracking the products that are causing this. And in Massachusetts in particular, Tufts University did a study, I'm sure you're very familiar with it, on CHS. And one of the things that I've critiqued a lot was that we diagnosed it, we talked about it, we did some follow-ups, but we never asked them, what were you taking exactly? And in a state that has a legal market, and we know every single product that's in the market, we also know that we still have smoke shops selling, CBD flower and unregulated, illegal, untested product. It is critical for public health to know what is causing it in our state. If we had such an increase, who's doing it, and why, and regulate that, and figure that out. So you've spoken publicly about CHS, and you've gotten a lot of backlash. So why do you think these conversations around cannabis harms become so emotional?
It's all goes back to prohibition, right? That we were taught that cannabis is bad and cannabis is dangerous, for decades, for 100 years. But now we know the cannabis is not dangerous, like itself. It's not going to cause death in people. So we're up against that. And then we also see people who are able to come off their prescription medications and say, what do you mean it's harmful? I'm no longer on prescriptions. I'm no longer in pain. I can sleep. Like, it's solving a lot of my problems in life. What do you mean it's causing issues? So people feel like they've already been lied to about it for decades. And then now then it's like this golden, this like, what's the word? Panacea. And then now we're saying, actually, it is causing some harm. And then people are conflating the reefer madness propaganda with actual evidence of it causing harm in some people. Oh, you're on mute.
Sorry, I was again blowing my nose a little bit. Yes, you're right on the money. I kid you not. I think the propaganda created an environment where people are very sensitive. It's like, don't call my baby ugly, right? And I think that that's creating an environment where science is now struggling to get a hold of folks and say, hey, FYI, there is an issue. And one of the things that I always like to bring up is that the reason the opioid epidemic had so much information is because there were drugs that we were tracking already. We were tracking prescription, how many prescribed. We were tracking harm reduction and substance use requests for opioids because they kind of upticked. And and it all started with, I like to say nurses, we kind of started this thing by making pain the fifth vital sign. So when you make something visible, typically the system responds. So when we started focusing on pain and pain management and trying to make people more comfortable, the knee-jerk reaction was give them more pain meds, make the pain meds last longer. And we saw what happened in that environment with, 10 years later, we're now going back and looking at the data and going, oh my gosh, we, 3x prescriptions and people are now in substance use programs. What happened and who's at fault? And then the finger pointing started, and now you're at fault, and then there's a lawsuit. And I think that we have an opportunity with cannabis to avoid public health harm and avoid an epidemic if we talk about things like CHS. So tell us, if you were to give us like a master class, what does the evidence actually tell us about CHS? What existing misconceptions exist about CHS? I will say that at times, if you disclose cannabis use and you actually have vomiting related to a GI issue, I know somebody who shared a story about their spleen basically damn near burst because they just kept sending them home, and they're like, "Oh, it's CHS," and because it became a thing. Like if you use cannabis and you're vomiting, it's CHS. So tell us a little bit about like what does the evidence actually tell us? Is there a differential diagnosis opportunity there in terms of assessment? How do we now keep clinicians like in a hospital that did this research from assuming every patient that consumes cannabis and has GI symptoms is a CHS patient?
Right. Yeah. And I will fully, like, as a CHS researcher and somebody who helps a lot of, patients with CHS, that overdiagnosis is absolutely an issue. That, patients go to the doctor and they have vomiting and then they disclose cannabis use and then they get slapped with CHS diagnosis. And the doctors aren't doing the work, the testing that they should be on other conditions that could be life-threatening. That's happening. But what's also happening is people are going years and years with these obscure symptoms, and it's years before they finally get a diagnosis and they realize that it has been cannabis use all along causing their symptoms. There's an author on our paper has CHS, and she's been diagnosed for a while, but she went 8 years before finding out that it was the cannabis causing her issues. So that's happening. And I just, read a comment the other day that like, oh yeah, my mom has been sick for 3 years and we finally got this diagnosis. So it's definitely like happening on both sides. But what we know about CHS is that it's this cyclic vomiting syndrome, and there are 3 phases to it. There's the prodrome phase that can last weeks, months, or even years, where people wake up feeling nauseous, they have malaise, they may be anxious, and then oftentimes they smoke weed, they feel better. And then this continues on for a long or short period of time, and then eventually it can develop into the hyperemetic phase, and that's where people end up in the ER with the screaming, the vomiting, severe abdominal pain, and often needing, IV fluids and some pretty hardcore nausea medications. And then they quit consuming, and then they eventually recover, which can take months, sometimes like up to a year or two to like fully recover. And the biggest misconception about CHS is that it's related to pesticides. And we have so much research or so much evidence that goes against that. And I'll like point out the things that we found in our own research when we surveyed over 1,100 people to get, we looked at their use patterns and where they were getting their weed and to see what we could find. And what we found was that symptoms were almost identical in both the prodrome phase and the hyperemetic phase, regardless of where people got their weed. So whether it was from a licensed place, an unlicensed place, home grow, their friends, symptoms were almost identical. So the fact that it pointing to, a single contaminant being present across all of those sources, but only getting a small subset of people sick with CHS is highly, highly unlikely, especially like from the regulated places. And home grow, people aren't using chemicals in their own home grow. And then the other piece that we found was that people are getting sick in withdrawal. They're trying to quit and they can't quit because they keep getting these CHS symptoms. We've had people go on vacation, don't take their weed with them, end up in the hospital with severe nausea, vomiting, and abdominal pain because they're in withdrawal. So find me a chemical or a contaminant that causes these symptoms when you take the chemical away. And what it's really pointing to is ECS dysregulation, and also the symptoms that people are experiencing. Body temperature changes was like one of the big ones. And what chemical causes body temperature changes? THC definitely causes body temperature changes. And when you take it away, it causes body temperature changes. So, and that, our ECS regulates our body temperature. So there's so much evidence out there that points away from the pesticide or contaminant theory, but people want so bad to believe that THC is not a problem at all. So they continue to perpetuate that it's a contaminant. That was
I have a personal question now that I'm thinking about it. Have we seen CHS with CBD use and only CBD use, or THC is the variable?
Yeah, see, that's a great question. In our study, 80 some people had THC as part of it. There were only 3 people out of over 1,100 who reported using CBD only in the 3 months prior to their symptoms. So like 0.3%. And I feel like if CBD was causing CHS, we would definitely see that in the real world. We would see that in, these pediatric epilepsy patients who are using hundreds of milligrams a day, or, chronic pain patients using high doses. And we just don't see that. We don't see prodrome symptoms. We're only seeing it in the context of heavy THC or other CB1 agonist use.
No, that's wow, that's fascinating. And where can we find this research? Is it published yet? Is it shared? How do people get a little deeper if they want to go a little deeper into a lot of this research?
So our research is currently published. When did we publish it? February of this year. You can just search my name on Google Scholar or PubMed, and then our survey shows up. That's just part 1. We are working on writing up part 2 right now, which is the second part, where we're looking at, the stigma that CHS patients face. We're looking at what medications work to see if there was any difference. We are looking at the withdrawal piece, because there's definitely it's a different subset of people who experience CHS in withdrawal. So we're seeing, that can all be found. Well, the second paper will be published later on this year, but the first paper is currently published. But you can just search Cannabis Hyperemesis or Cody Peterson or my name, and the paper comes up. It is behind a paywall, unfortunately, and it would have cost thousands of dollars for us to get open access. So it's behind a paywall right now.
No, understood. Listen, peer-reviewed research is how we kind of live in this space in science and medicine.
Right.
And it's critical to keep doing that work. So I'm grateful that you're doing this work, because I think it's so fascinating, especially since I've been kind of writing a little bit around, and I'm actually working on a piece right now with a couple of colleagues, including Megan Mbengue, which we both know, about, here are evidence-based improvement efforts in hospitals, and what we can do to actually track CHS, and really start to create evidence-based prevention and data, so that public health is not impacted.
Diagnosis. The doctors aren't asking how much are you using, what are you using, how often, when did you start, because those things make a difference. If somebody's just like smoking a joint twice a week, but they're presenting with these symptoms, I would be like, that doesn't sound like CHS use patterns, and doctors aren't able to differentiate that right now.
So I'm going to ask you straight out, what should clinicians know? Like if I come in and I say, I'm a social smoker, I smoked at a party last week and I'm having severe vomiting. And the doctor was like, oh, it's probably CHS, right? What would they know? What do they need to know to be able to kind of differentiate?
Yeah. I want to like fly in with a cape and be like, no, you're wrong. If you just smoked once last week and then came in sick this week, that does not sound like CHS. And what we found is 96% of the people in our survey are using cannabis daily, and like 85% are using it like 3 or more times a day. So it's definitely like daily use and chronic use. And we found that people who are using concentrates like vape pens are developing in a much faster time frame than those who are smoking. Like the most common time frame was like 2 to 3 years for those using vapes, and then like 10 plus years in those who are smoking. So we hear a lot of times, oh yeah, I've been smoking for 50 years and I haven't had an issue. But then we have people that are like, I would smoke for 50 years and then develop CHS. So doctors need to recognize that, like, they need to ask the questions. What are you using? How often are you using it? Because just sparingly, a couple times a month, that doesn't fit the typical CHS patient use pattern. It's usually heavy daily use is what we see.
No, that's good to know. And on the other side is the patient, because in our healthcare experience survey, we're assessing disclosure and the risk around disclosure in particular, and then co-exposure to evaluate drug-drug interaction risk prevalence. And as most of the people in our survey, because we actually did a very non-traditional data collection strategy, I parked myself at dispensaries and was only talking to consumers that were accessing the plant. I wanted to know, what are the use patterns of people who are actually using cannabis here? Because a lot of the research has use patterns of people who may or may not have used cannabis. And cannabis use, I believe it's like once every 30 days, you're considered to have like cannabis use. And most people are using cannabis daily, including myself, right? So if you're using cannabis therapeutically daily, what should I know as a patient and watch out for to see like if I'm developing CHS?
Right. So what we know why, like, not everybody who uses cannabis daily will develop CHS. That's so important, that it is a subset of users. Current research points to, maybe 20% of daily users. I think that's, or like 18-ish. I think that's a little bit high, but there are people in CHS community that say that that's actually low, that there are more people with CHS. But there looks to be a genetic predisposition to those who have CHS. Those with family members with CHS may be at higher risk. But what people want to look out for is the early symptoms of CHS, and that is the morning nausea. Are you waking up not feeling so good? And if that nausea was not there before the cannabis use started, then it could be contributing, or it could be the cause of the nausea. So that's like one of the early symptoms. People will often report that they're heavy cannabis user and they have one drink with alcohol in it, and then it makes them violently ill. And I get so much flack for pointing this out. They're like, well, alcohol is a poison, people shouldn't be consuming it anyways, why is that a bad thing? It's like, well, but we should, like, the human body is able to tolerate one drink, right? And the fact that we can't tolerate it is an indicator that there's something else going on, and it could be heavy cannabis use contributing to that. So it's just like a flag that maybe this is something I need to keep an eye on, and maybe it's something I need to do something about. We also found that stress was I think stress was the #1 trigger of CHS symptoms. So those who developed CHS said that they may have had the prodrome symptoms, but it was usually some sort of stressful or traumatic event that threw them into the hyperemetic episode. So just being on the lookout for the early symptoms is, the best recommendation for people. That, like, if you're waking up with nausea, maybe it's time to just take a look at the cannabis use, and maybe we need to switch some things around.
No, that's so helpful. I'm somebody who encourages journaling a lot with people when they're asking me, hey, I want to try cannabis. And I'm like, you need to start low and go slow and document everything. Because you won't know your patterns and you won't know what it's doing to your body until like you're looking at the data in front of you. And I think that all of us need to be encouraged to be like little researchers for ourselves if you are a cannabis consumer, to really start to look at cannabis as something that you're trying and you want to evaluate how it works and if it works with your body and your anatomy.
Yeah.
And it makes me also wonder, like, what other risks that you think we're underestimating when it comes to cannabis and THC consumption? What is healthcare underestimating about the plant? Because again, we don't talk about the bad.
Right.
Is there anything else that's emerging or that we should be looking at?
I mean, I think there's a lot that we should be looking at. And I think we need to recognize first that, like, the cannabis of today is not the cannabis of decades ago. The brick weed was 2 to 4%, maybe. And now we're pushing 20, 25%, depending on the lab, of course, THC. And then we have these high concentrates that are 70, 80, 90% THC, which I think is way more THC than our ECS was designed to handle. So, recognizing that's the big reason we're seeing all these issues now, and we didn't see them decades ago, is because of the increase in potency in products, and then the normalization of heavy daily use also. So that being said, what was the question? I'm sorry.
No, the question was like, what are we underestimating? Like,
the other risk.
Is there any other emerging risk? Like, and I mean, you're right. I want to just add to that. The cannabis that people were using in the 70s was not being marketed, and I think marketing getting high was like the worst thing we could have done. Like, I think we should have marketed homeostasis. We should have marketed the therapeutic impacts of the plant. And now we're out there swimming dead in the center of the ocean, and like we're looking for a life raft, and we don't have one because we've gone and jumped off the deep ends. So I believe that the data is going to have to guide legislation to say, hey, maybe we don't sell these high dose products, or hey, let's bring everything back to like where it wasn't causing harm, but we don't have the information to do that. And I think that's something that's going to continue to reinforce stigma for the plant if we don't start to put science behind it. But I guess the question still remains, is there any other risk that we're underestimating when it comes to cannabis in healthcare?
I mean, there's definitely the risk of psychosis, and that's like the acute losing touch with reality. And that can happen to anybody. It usually happens with edibles. They just take too much, or they didn't wait for the first one to kick in and took the second one, and then they're having hallucinations and symptoms of psychosis. And what that can do is, for some people who are at risk, that can develop into schizophrenia later on. And we want to see less of that. So we see that mental health, and bipolar is also a piece of that. We do see worsened anxiety and depression in those who use cannabis heavily. Like it helps at first. It definitely like triggers a dopamine release at first, but then down the line with heavy use, it actually decreases our dopamine. And so we're getting less of that. So we see worsened mental health outcomes with that. And we see people using it as an escape from reality when they feel uncomfortable. I'm just going to hit my pen because I feel uncomfortable right now. And it's a form of escapism. So it's not handling their emotions. They're not learning effective coping mechanisms. So they're just, kind of numbing out. And we see that a lot. And that is not a good long-term strategy. My friend Ariane says that like escapism is a place to vacation, not a place to live. And we see a lot of people living in the escapism right now with heavy use of THC. There are cardiac events happening, I think, with a lot of the synthetics and the smoke shop high potency products. We're seeing cardiac events. With long-term smoking, we can see chronic bronchitis, inflammation of the lungs. So there are issues related to it when it throws us out of balance. Yes, it can help bring us back into balance, but heavy use can throw us out of balance. And people are losing sight of that possibility that, cannabis is great. No matter how much I use, it's going to bring me into balance. But that's not true. That's not what happens in the body.
No, absolutely. Just because you can't overdose from it doesn't mean it can't harm you. Right. Which brings me to like a unique question, because I think that you are a great communicator of this information. So how do we communicate risk without reinforcing stigma, or how have you been able to do that?
Boy. Reinforcing risk without creating stigma. It's so hard because I can't even post clips of me talking about cannabis and like objectively, like how THC can turns down the signaling in our saliva glands. Then that's why we get dry mouth. I can't post something like that without people calling it propaganda and reefer madness and getting angry about it. It's so crazy. You should see the comments. And I don't know. I don't know that I have mastered that yet, because people don't want to hear about cannabis from a medical professional. They want to they want to hear about cannabis from influencers who can tell them what they want to hear and in their echo chamber. And they get really angry about anybody who challenges the narrative until they themselves start experiencing those adverse effects. So I have not mastered that yet. I'm working on it. I'm definitely poking the bear and getting bit a little bit, but I'm not sure.
No, I think of I agree with you. I think sometimes I'm often looked like with a side eye when I say we need better labeling, and I think there should be warnings on products that patients to their physician. Hey, if you're on a blood thinner, talk to your doctor before taking this. Like when I pick up my antibiotics, they tell me not to drink wine while I'm on these antibiotics. And I don't get mad about that, right? I just understand that when I'm using this medicine, if there's another thing that would make the medicine not act the way that they intended it to act when they prescribed it, that I should be warned about it. And I think that is something that we're not acknowledging and we are not pushing forth, because the industry has so much power because of their financial capacity that they're able to just shut it all down. And I always say I like to come in a Trojan horse. So if we can collect the data and kind of push the language in that information and prove it with numbers that we can do better, that's actually when things are going to change and people won't feel threatened. In Massachusetts, there's a particular sensitivity to talking about the negative parts of cannabis. Specifically this year, we have, I don't know if you've heard of SAM, Smart Access. I can't remember. I don't even know what SAM stands for, but they're just a really rich group of people that are not very big fans of cannabis. They're actually suing the federal government right now because of the rescheduling. They're just mad. And in Massachusetts, they were able to garner enough signatures to get a ballot question that would repeal the entire adult use market. And it would repeal the entire adult use market, and it would not criminalize marijuana, which means we're going to close every shop, but it's not illegal to have it, and you're not going to be able to grow it at home. So where are people going to go? Especially when we've bastardized the medical program. It has shrunk by 50%. We don't have enough providers to actually really certify the number of people that are using and accessing the adult use market. So there's going to be this gap period if this goes through, where people are just going to be like in the streets in the black market, practicing medicine, like, you know, the times where it was unsafe and dangerous and untested and unregulated. So I think that closing every adult use shop would make us lose visibility.
Yeah, that definitely doesn't solve the problem. I think that, you know, is a solution in like the healthcare education, so that doctors can have these conversations with their patients in both an empathetic and comprehensive way. That's, you know, because, you know, when I go to my doctor, it's still like just the illicit, are you using marijuana? And I'm just like, I use CBG and CBD. Do you care about like those doses, you know, or are you curious about them? And that those conversations definitely aren't happening. And I think that had those conversations been happening decades ago, we would not see the CHS. We would not see this. I mean, not to the degree that we do. We wouldn't see this pendulum swing and this potency chasing, because that's where we're seeing the adverse effects, is with the heavy use of high potency. We're not seeing it so much in low potency therapeutic use, you know, clinician guided.
Yeah, no, and I would certainly agree with you, but I'm also going to play the devil's advocate because that's what I do.
Mm-hmm.
What happens to the people who have been criminalized, have been jailed, and have been disproportionately impacted by the war on drugs, that just want the freedom to use the plant as they have been using? How do you tackle that population that is saying, I don't want to have to go through a doctor to consume my cannabis? And I feel like I always compare it to Tylenol, as if I just have a headache and I need some Tylenol, I can go to CVS and get it over the counter. If I have a procedure and I need like extra strength Tylenol, I need a gram, I need medical supervision, because 4 grams of Tylenol will start to cause harm to my body. So if they give me a gram pill, I have to only take 4 a day. And like, it's the same concept that if you need more cannabis than what we think therapeutically should be getting used, that you should have some clinical guidance. And I think people are afraid to lose their autonomy to make those decisions for themselves, because this has been so accessible to folks without having to go through the healthcare system. So I guess my question is, like, what are your thoughts on like, how should cannabis exist in our U.S. healthcare system, from your perspective?
Yeah, I think that it should absolutely be available and accessible, like as an OTC, you know, like we have on the hemp market. However, having, you know, I don't think that it should be required that patients go to a doctor to get it, but I think that patients should be able to get guidance from the doctor, or, you know, guidance should be somewhat standardized like it is for Tylenol. Like, we know we're not mixing Tylenol with alcohol. We know we're not taking more than X grams a day of like, those safety parameters are in there, but we can still access it easily. And I think that a model like that should be similar for cannabis. And then again, like you said, if we need something more intense therapy, then maybe that's something that we go to a doctor for. Or we have the doctor say, hey, you know, maybe you don't need 500 milligrams of Tylenol. Maybe it can be achieved at 3 at 25, and you add in this other thing. Maybe you add in turmeric for your inflammation. And so something along those lines, that like, it's more like guidance and education, not so much like a prescription model.
No, yeah, absolutely. I like that. I definitely agree. As we're getting close to like our closing, of course, because these conversations fly by because they're so good.
Yes.
But I like to dream out loud with my guests on this show. And I'm thinking, if you could immediately fund 3 cannabis studies today, what would they be? What data would be collected? And what would you invest in?
Yeah. I mean, what I'm interested in is like, one, like PK studies, which is like the blood level studies, in suppositories. in both like vaginal and rectal delivery. I want to know that because there are people using high dose suppository therapy for their cancer and it's working, but we don't have any evidence showing how much is actually getting and circulating in the bloodstream. So that's one. And I think that Stacy Gruber is doing that work in Massachusetts right now. So hopefully we'll have that data by CanMed next year. I am also curious about those who experience severe withdrawal versus those who experience, minimal withdrawal from cannabis, and what is their genetic makeup that makes them different? What else is different? And then let's see here. I would love to see more on like THCA on the acids and CBGA and CBDA, because we're seeing incredible outcomes in our patients who are using those medicines. So that's
Oh, I love that. I love that. Throughout these conversations I've had, I would say hundreds at this point. It's been a couple of years since we've been gathering this data and documenting it. I found that I was talking about cannabis, but I wasn't just talking about cannabis. I was talking about like the fact that we can't see when a new phenomenon enters healthcare. Like we just don't have, like the knowledge gap is a visibility gap, because cannabis is in front of us right now, but psychedelics are right behind it, right? So if patients aren't disclosing because of the stigma, and clinicians aren't documenting because they don't have an education, and then EHRs don't even have the fields for us to document them in, and we don't have the ICD codes, how does that affect the research that we're capable of doing now? And how does that affect clinical care?
Oh, I mean, like, I think it affects it big time. Well, first, I think that there are workarounds without that, and that is collecting the real world evidence, which is what we're able to successfully do right now. But yeah, we're not. Is there an ICD-10 code for uses cannabis therapeutically, uses cannabis for pain? Does that exist, or is it just cannabis use disorder? Now we have one for CHS. We're not even a year into having that code, but that's there. But yeah, I think it greatly impacts it.
When you were saying that, I was thinking the reason we have these ICD codes is because people want to get paid, right? And no one has invested in wanting to get paid to prove the rights of cannabis and therapeutic, impacts of cannabis. So the more work that you and I and all the clinicians are doing a lot of this work do, the more evidence that they'll have to say, maybe we just need a therapeutic cannabis use ICD code. Because like you said, CHS, the reason we have the code is because they were like, okay, how are we going to get reimbursed for this?
Right.
And then track it. And I think that's super critical. So we're going to close out with my favorite thing, which is daydreaming, right? So 10 years from now, what does a good cannabis integrated healthcare system look like to you?
Ooh. What I would love to see is, I would love to see like cannabinoid use, like FDA approved IV cannabinoid therapy in the hospital, IV CBG for sepsis. I think I would love to see that. And then, there is space for pharmaceutical cannabinoids, and I would love to see that in acute care. But then for chronic conditions and wellness, I want to see whole plant medicine, both as like prevention and treatment for these things. And I want to see doctors who are actually educated on the ECS and cannabis and terpenes and all of that to be able to guide the patients who then have access. And we're not chasing THC potency, or we're not chasing a high, but we're like chasing balance and wellness.
No, I love that. The IV idea. Oh my gosh. I didn't think about that, because I'm thinking about the anti-inflammatories and how we go in sometimes, and that would be magical if we could have the most powerful anti-inflammatory we know about actually doing its job in the body in a safe way, in a controlled environment. I like that. Thank you.
Mm-hmm.
Thank you for that. That is pretty awesome. Now, Megan, Megan, you've been so magical.
Oh, great.
You've been so
So
magical,
fun.
and I appreciate you. Thank you so much for joining us. I appreciate your willingness to engage in nuanced conversations that recognize like both the promise and the limitations of cannabis and cannabis research
Mhm.
and cannabis in healthcare. I think when we are willing to be curious and ask difficult questions and have these difficult conversations and let the evidence guide our decisions, that we're going to do a lot better in terms of our patients and actually upholding our oath of doing no harm. So I really appreciate your insight. I appreciate your work. To our audience, if you enjoyed today's discussion, again, please like and subscribe. Where can our guest find you, Megan?
Well, if you guys are interested in our products or services, we have an amazing line of hemp products. They can be found at EntheaCare.com. We guide people on how to microdose psilocybin mushrooms as a service. That's all on EntheaCare.com. And then I'm all over the socials, so people can search my name or they can search EntheaCare on social media platforms, and I'm there putting out content almost daily on
Oh, I love that. I love that.
psychedelics and CHS and research and all of that.
No, that's absolutely. I'm gonna actually put your website on the ticker if I can. And then I will actually share this as well. So thank you again for your time, for your energy, for your work. And I'll catch everybody else next week on another episode, actually, in our final episode of Let's Talk About Cannabis and Healthcare, because it'll be the one leading up to my book launch. So I'm going to do a shameless plug. So
Yay.
I wrote a book called Healthcare Cannot Manage What It Cannot See. And it is, I didn't mean to write a book, honestly. I was just like researching why we had a problem and how we were going to fix it because we need to fix it, and ended up writing a bunch of white papers that turned into the book. And on August 8th, we're going to be launching the book virtually at a private conference, invite only conference. I'm going to put kind of a book cover on there, and we're going to be talking and having working sessions, trying to figure out like what do we need to do and how do we then get this to actually happen for our folks and for our patients, and how do we build the infrastructure that healthcare needs to properly integrate cannabis into healthcare with what we already have, because we've done it for opioids, we've fixed ourselves for alcohol, we built harm reduction programs for a lot of use disorders except for cannabis, and I think we need to start doing the work. And waiting on the government to tell us that we need to do the work is not the way nurses work. That's why we're doing this work. So I think it's important for us to just kind of pull that out there. And if anybody's interested in joining us, they can reach out to me on LinkedIn or on the Cannabis and Healthcare Instagram page and request an invite to the event on August 8th. It's going to be from 12 noon to 3 p.m. Eastern or 9 a.m. to noon Pacific Standard Time. Thank you again, Megan. I appreciate you. And
Thank you for having me. This is a great conversation.
absolutely. Thank you. See you guys next time.
Bye.
Bye.